Medical emergencies in pediatric dentistry. 2. Contents. Introduction. Medical risk determination. Rationale in emergency management. Medico legal aspects. Steps in preparation of the emergency in dental office. Treatment protocols in medical emergency. Emergency kit. Emergencies in pediatric dental practice. Conclusion. Previous questions. References. 2. 3. Introduction. Sudden, urgent, usually unforeseen occurrence requiring immediate action. Dorland's Medical Dictionary can occur anywhere, even in a dental office. Due to a variety of causes: child's pre-existing medical condition, an airway obstruction caused by dental material, or problems related to a sedation procedure. 3. 4. Prompt and organized therapy can usually save a life. Responsibility of the pediatric dental surgeon to be prepared to recognize a medical emergency and render appropriate care. Many medical emergencies in dental office are fear-related. Therefore, if fear and apprehension are reduced, the chances of having a medical emergency are also reduced. 4. 5. Medical risk determination. The best treatment for medical emergencies is prevention. By consulting the physician of the patient, emergency complications can be minimized or the severity of the complication can be reduced. Hospitalization may be required sometimes due to seriousness of the illness for the dental procedure to be carried out. A best practice dictates that dental personnel must be prepared to provide effective basic life support and seek emergency medical services in a timely manner. 5. 6. Rationale in emergency management. Recognize that a problem exists. Diagnose the problem correctly. Activate the emergency medical service (EMS) system immediately. Keep the patient alive until better trained personnel arrives. Remain calm and act swiftly and definitely. Never administer drugs without definite indication. 6. 7. Medico legal aspects. For medico legal aspects, a written record of the following should be kept: time of onset, vital signs elicited during the emergency, effects of drugs and therapy provided, time, name, dose, and route of drugs administered, time of initiation of cardiopulmonary resuscitation, status of the patient at the time of transfer to EMS system. 7. 8. Preparation of the emergency in dental office. It is imperative that all dentists and staff members master BLS at the healthcare provider (HCP) level of training. Advanced Cardiac Life Support (ACLS) and Pediatric Advanced Life Support (PALS) are required if providing office-based sedation. Personal preparation. The dentist must be prepared to quickly carry out an action plan to manage the situation. Personal preparation for the dentist should include, at a minimum, a working knowledge of the signs, symptoms, course, and therapy for common treatable conditions. 8. 9. 2. Staff preparation. The office should have an emergency plan in place. Responsibilities of the team include, assisting the dentist, providing patient care, staff to call 108, staff for documentation, staff for assisting other patients and family members, staff to direct EMS to the patient. Regularly scheduled mock medical emergency drills will keep the team protocol running smoothly and reduce panic in an actual emergency. 9. 10. 3. Backup medical assistance. The dentist and staff should be expected to manage a medical emergency until EMS arrives. Dentists and staff should not rely on other physicians in close proximity to help manage emergencies. It is the dentist's responsibility to be prepared to handle the emergency until EMS arrives on the scene. 4. Office preparation. Emergency equipment. Emergency equipment for pediatric patients must be appropriately sized, infant through adolescent, and available. 10. 11. Treatment protocols in medical emergencies. Emergency guidelines: P rightward arrow, C rightward arrow, A rightward arrow, B rightward arrow. D position: P circulation, C airway maintenance, A breathing, B definitive care, D 11. 12. I position for a conscious patient, whatever position is comfortable for the patient. For an unconscious patient, all unconscious patients should be placed in a position to increase cerebral flow with minimal interference with ventilation. Place the patient in a supine position, head at the same level as the body, feet slightly elevated, 10 to 15 angle, 12. 13. 2. Circulation: if the infant or child is unresponsive and not breathing, preferred. In adults and children, carotid pulse; in infants, brachial pulse. If within 10 secs no pulse, begin chest compressions. If pulse 60/min with signs of poor perfusion despite support of oxygenation and ventilation, begin chest compressions. 13. Take up to 10 secs to attempt to feel for a pulse. 14. 15b. Airway management: most common cause of airway obstruction, tongue. Children with enlarged tonsils are particularly more vulnerable. To open obstructed airway, head tilt, chin lift maneuver. For unconscious patients, oral or nasal airway devices. These devices not to be used in conscious, as it tends to induce gagging and vomiting. 15. 16c. Breathing: once a patent airway is established, adequate breathing should be ensured. Breathing should be checked by feeling and listening to the chest, nose, and the mouth. Look, listen and feel if patient is not breathing. Rescue breathing should be initiated. Initially 4 breaths are given and later 1 breath for every 3 sec to expand the chest. It can be accomplished using mouth or bag valve mask. 16. 17. Mouth-to-mouth ventilation gives only 18% of oxygen, and so its efficacy is less. Bag valve mask, which fits tightly over the patient's mouth, will deliver 100% of oxygen. This mask is a one-way valve which allows oxygen to enter the patient when it is squeezed, and the empty bag gets refilled with the oxygen. 17. 18. Definitive therapy: once the patient is positioned and circulation, airway, and breathing are managed, then various treatment options, including drug administration, should be considered. If the cause is clear or was precipitated by a treatment or drug administration, definitive therapy may be indicated and essential. 18. 19. Video: how to do CPR on child, 1 to 12 YRS. 19. 20. Emergency kit. 20. The drugs and equipment in the emergency kit are intended for use in patients of any age, pediatric, adult, or geriatric. Doctors must be aware of the distinction in therapeutic doses between patients of different ages. Pediatric doses are smaller than adult doses. 21. Emergency drugs recommended: emergency drugs for pediatric office, 21. Epinephrine, glucose, oxygen, albuterol, aspirin, naloxone, midazolam, flumazenol, nitroglycerin, diphenhydramine. 22. 23. Diphenhydramine. 23. 24. 25. 26. 27. Critical emergency equipment: oxygen delivery system, self-inflating bag valve mask device, pocket mask, automated external defibrillator, syringes, suction and suction tips, patient monitoring devices, stethoscope, pulse oximeter, glucometer, blood pressure cuffs, pediatric and adult. 27. 28. Secondary emergency equipment: oropharyngeal and nasopharyngeal airways, laryngeal mask, airway, laryngoscope and endotracheal tubes, scalpel or cricothyrotomy needle. 28. 29. Whenever possible, drugs in solution should be in a prefilled syringe. The use of intravenous, IV, drugs in dental practice should be discouraged. Inhalational, sublingual, buccal, and intranasal routes should be preferred. All drugs should be kept in an emergency drug container. Oxygen cylinders should be of sufficient sizes to be easily portable, but also allow adequate flow. 29. 30. Emergencies in pediatric dental practice: unconsciousness, syncope, orthostatic hypotension, adrenal insufficiency, respiratory difficulty, airway obstruction, hyperventilation, asthma. Drug-related emergencies: anaphylaxis, sedation, overdose, cardiac emergencies, acute coronary syndrome, cardiac arrest, diabetes mellitus, hyperglycemia, hypoglycemia, neurologic emergencies, seizures. 30. 31. Unconsciousness, vasovagal syncope, orthostatic hypotension, adrenal insufficiency. 31. 32. Unconsciousness/syncope. Unconsciousness is rarely noticed in younger children except in the presence of some underlying disease. Psychogenic reactions are infrequent in this age group, because children are unable to express their feelings towards dentist. Causes of fainting are vasovagal syncope, orthostatic hypotension, adrenal insufficiency. 32. 33. Vasovagal syncope, loss of consciousness secondary to stress and anxiety. Defined as transient loss of consciousness due to cerebral ischemia caused by less blood supply to brain. 33. 34. Sign and symptoms: 34. Presyncopal, early, feeling of warmth, pale or ashen gray skin tone, heavy perspiration, feeling of fainting, nausea, tachycardia. Late, pupillary dilation, yawning, hypernia, cold hands and feet, hypotension, bradycardia, dizziness, loss of consciousness. Syncopal breathing may become irregular, jerky and gasping, or quiet and shallow. Pupil dilatation with patient showing death-like appearance, convulsive movements and muscular twitching of hands, legs, or facial muscles. Post-syncopal pallor, nausea, weakness, and sweating lasting for few minutes to several hours. Immediate post-syncopal phase, patient may experience a short period of confusion or disorientation. BP, heart rate return back to normal slowly. 35. Management. 35. 1-0-8. 36. Orthostatic hypotension. Postural hypotension is defined as a drop in systolic blood pressure, BP, of at least 20 mm Hg or of diastolic BP of at least 10 mm Hg within 3 minutes of standing when compared with blood pressure from the sitting or supine position. Only infrequently associated with fear and anxiety. Etiology: poor physical condition, obesity, medications, antihypertensives, antidepressants, narcotics, anti-Parkinson drugs, prolonged supine position. 36. 37. Dental therapy considerations: patients who have been in a supine or semi-supine position throughout long appointments cautioned against rising too rapidly. These patients should resume an upright position slowly at the conclusion of treatment. As the patient stands, the clinician may want to stand close to the chair until the patient is able to stand without feeling dizzy. If the patient does become weak or faint, however, dental staff members are close enough to prevent the patient from falling and possibly suffering injury. 37. 38. Prodromal signs and symptoms associated with vasodepressor syncope are rarely noted. Clinical signs and symptoms more often, in patients with other predisposing factors for postural hypotension, such as the administration of drugs. Such patients may show some or all of the prodromal signs and symptoms of vasodepressor syncope before consciousness is lost. Blood pressure is quite low. The heart rate remains at the baseline level or somewhat higher. If unconsciousness persists for 10 or more seconds, patient may exhibit minor convulsive movements secondary to cerebral hypoxia/anoxia. Consciousness returns rapidly once the patient is returned to the supine position. 38. Signs and symptoms. 39. Management. 39. 40. Acute adrenal insufficiency least likely to be seen in the dental office. The condition, though uncommon, is potentially life-threatening, but readily treatable. Acute adrenal insufficiency is a true medical emergency in which the victim is in immediate danger because of glucocorticoid, cortisol, deficit. 41. Before dental treatment, thorough medical and dental evaluation should be completed. Provisional treatment plan established. Patient's primary care physician consulted a history of past or present tuberculosis, HIV, or histoplasmosis increases the risk of acute adrenal insufficiency secondary to opportunistic infections that can attack the adrenal gland. 42. Signs and symptoms. In potentially stressful situations such as dental surgical procedures, patients with hypofunctioning adrenal cortices may exhibit clinical signs and symptoms of acute glucocorticosteroid insufficiency. The result of this acute insufficiency may be the loss of consciousness and possible coma. 42. 43. Management. 43. 44. 2. Respiratory difficulties, airway obstruction, hyperventilation, asthma. 44. 45. Airway obstruction, severe or complete upper airway obstruction due to a foreign body rapidly progresses to unconsciousness. Causes: food, 50%, and small objects, 50%. 45. 46. Signs: tachypnea, wheezing, patient sitting upright using accessory respiratory muscles, cyanosis, agitation and confusion. Symptoms: dyspnea, increased cough, feeling of chest congestion or tightness, feeling of suffocation. 47. Management: if patient conscious, allow him or her to expel the object with his or her own efforts by coughing. If this is ineffective and patient shows universal signs of choking, then deliver abdominal thrusts. Heimlich maneuver: for patient on dental chair, abdominal thrusts is modified by delivering the thrust with the heel of the hand from the side or front of the patient. 47. 48. Abdominal thrust not to be performed in infants because of their relatively large abdominal organs, especially the liver, which could be damaged. In these cases, a chest thrust maneuver and back blows should be delivered. 48. 49. If a foreign body is visible, remove it. Do not perform blind finger sweeps as it may push obstructing objects farther into the pharynx and may damage the oropharynx. Attempt to give 2 breaths and continue with cycles of chest compressions and ventilations. If ventilations are difficult because of the obstruction, reattempt head tilt/jaw thrust and consider an oral or nasal airway. Caution when placing an airway so as not to distalize the foreign object, worsening the obstruction. 49. 50. Dentists with training may perform laryngoscopy, endotracheal intubation or cricothyroidotomy, if skilled in these techniques. 50. 51. 52. Prevention: use of rubber dam isolation, rotary files preferred over hand files. If using hand files, tie dental floss 18 or more. Avoid working in wet environment which may cause slippage of instrument. Use of gauze throat pack. Use of high velocity suction. Use of more upright position if possible. 52. 53. Video, first aid for choking. 53. 54. 2. Hyperventilation: increased spontaneous ventilation beyond that required to maintain homeostatic concentrations of oxygen and carbon dioxide. Often triggered by an anxiety-provoking event such as local anesthetic administration. The patient is usually unaware of the fact that he or she is breathing rapidly. Rarely seen in children. 54. 55. Clinical features: RR 24 to 30, elevation of PAO2 and decreased PACO2, respiratory alkalosis, stabbing, chest pain, numbness and tingling of the extremities and perioral area, muscle twitching, cramping, seizures. Patient rarely loses consciousness. 55. 56. Prevention anxiety, preoperative identification and reduction record vital signs management stop dental procedures remove materials from mouth reassure the patient comfortable position of patient guide breathing rebreathing exhaled air use of paper bags cupping one's hand oxygen is not indicated 56. 57. Asthma disease characterized by an increased responsiveness of the trachea and bronchi to various stimuli and manifested by widespread narrowing of the airways that changes in severity either spontaneously or as a result of therapy. American Thoracic Society, classification, according to causative factors, intrinsic, no H/O allergy extrinsic, H/O allergy extrinsic asthma common in children 57. 58. Signs and symptoms coughing wheezing dyspnea chest congestion use of accessory muscles anxiety, restlessness, apprehension tachypnea, tachycardia increase in blood pressure diaphoresis, confusion nasal flaring cyanosis 58. 59. Management of asthma begins prior to an emergency. Evaluate severity of patient's asthma-free access to metered dose inhaler, MDI. Dentist should be well versed with the technique of taking MDI reduce any predisposing factors from the environment such as stress, airway irritants remove any objects present in the mouth that can obstruct airway or be aspirated. 59. 60-60. 61. Seizures are clinical manifestations of paroxysmal excessive neuronal brain activity. Generalized tonic-clonic seizures, grand mal epilepsy, may be life-threatening. 61. 62. 4 phases of tonic-clonic seizures, prodromal phase, subtle changes that occur over minutes to hours usually not clinically evident to the practitioner or the patient oral phase, neurologic experience that the patient goes through immediately before the seizure may consist of a taste, a smell, a hallucination, motor activity, or other symptoms. Ictal phase, rapid jerking of the extremities and trunk. Breathing may be labored and patients may injure themselves. Usually lasts 1 to 3 minutes. Postictal phase, muscles relax and movement stops. A significant degree of CNS depression caution must be exercised in the postictal phase as there may be respiratory depression 62. 63. Management P position supine. C. A. Be assessed as adequate, respiratory and cardiovascular stimulation are noted during the seizure. D. Definitive care protect victim from injury. Keep victim in the dental chair, gently hold arms and legs, preventing uncontrolled movements, but do not hold so tight as to prevent all movement. If parent or guardian is available, bring them to the treatment room to assist in assessing the victim. Summon EMS if the parent or guardian of the patient suggests it, or if the seizure continues for more than 2 minutes. Most tonic-clonic seizures stop within 1 minute and almost always within 2 minutes, thus the recommendation for EMS with prolonged seizure activity. At the conclusion of the seizure, P rightward arrow C rightward arrow A rightward arrow B rightward arrow D must be reassessed. 63. 64. Prevention, comprehensive knowledge avoidance of situations provoking seizures verify that patient continues anti-seizure medication on the day of dental treatment decrease stress and anxiety 64. 65. Drug-related emergencies anaphylaxis sedation overdose 65. 66. Anaphylaxis it is a potentially life-threatening immune reaction to a foreign body. The anaphylactic reaction is mediated by the release of the histamine from sensitized mast cells. Known triggers: penicillins, latex sulfite, antioxidants in local anesthetics containing vasoconstrictors, ester type local anesthetics 66. 67. Skin reaction, intense itching, erythema, angioedema, urticaria over face and upper chest, gastrointestinal reactions, abdominal cramps, nausea, vomiting and diarrhea, urinary incontinence, respiratory reactions, cough, wheezing and dyspnea, chest tightness, cyanosis, bronchospasm, cardiovascular system, palpitations, hypotension, tachycardia. 67. 68. Management of anaphylaxis depends on time, course, and severity of symptoms. For minor reactions, oral diphenhydramine 25 to 50 mg or 1 mg per kilogram. The patient should be monitored to make sure symptoms do not worsen. For anaphylaxis, terminate the suspected agent, begin basic life support protocol, activate EMS, and administer 0.15 mg of epinephrine. Administration may need to be repeated every 5 to 15 minutes if symptoms reoccur and EMS is not yet on the scene. Oxygen therapy, 2 puff of the albuterol inhaler, and diphenhydramine may also be administered. The patient who suffers from severe anaphylaxis must be transported to the hospital for additional treatment with antihistamines and corticosteroids. 68. 69. 2. Sedation overdose. An overdose of sedation is general anesthesia, though general anesthesia represents a controlled state of unconsciousness, whereby with oversedation unconsciousness is achieved unintentionally. Effective management of a patient receiving general anesthesia is predicated on airway management and ventilation. 69. 70. Management. P. Position supine. C. A. Be assessed and managed as necessary. D. Definitive care. Monitor the patient with a pulse oximeter, blood pressure, heart rate, and rhythm. Stimulate the patient periodically, verbally or by pinching the trapezius muscle, seeking response. Antidotal drug therapy. Administer forflumazenol in a dose of 0.2 mg, 2 ml, in 15 seconds, waiting 45 seconds to evaluate recovery. If recovery is not adequate at 1 minute, an additional dose of 0.2 mg may be administered. Titrate for naloxone at 0.1 mg, 0.25 ml, per minute to a dose of 1 mg if an opioid was administered. EMS may, or may not, be summoned, depending on the clinical situation. 70. 71. Diabetic emergencies. Diabetes mellitus is a disorder involving poor insulin production and hence elevated blood glucose levels. Type 1 or insulin-dependent diabetes mellitus occurs most commonly in children. Emergencies in children may be the result of hypoglycemia or hyperglycemia. 71. 72. Hyperglycemia. 72. Diabetic ketoacidosis. Ketoacidosis requires several days to develop, during which time the patient appears ill. It does not occur suddenly in a previously alert and well patient. Therefore, this disorder will generally not lead to an acute emergency in the dental office. If the diabetic patient does not look well, and particularly if the breath has an acetone-like odor, he or she should be instructed to seek medical attention immediately. 73. Management of hyperglycemia. Test blood glucose using glucometer. Notify parents if over 250 mg/dl. Hydrate patient using oral fluids. Administer insulin dose according to medical plan. 73. 74. Hypoglycemia. Blood sugar less than 40 mg/dl. Children, rapidly occurring clinical features, tachycardia, sweating, nervousness, irritability, confusion and slurred speech. 74. 75. Management of hypoglycemia. Place the patient in a position of comfort and assess, CABS, the patient. Definitive therapy. If patient conscious, oral glucose tab 37.5 g and repeated as necessary. Sugar dissolved in juice or a sugar-containing soft drink may also be used if patient unconscious. Initiate BLS and give 450% dextrose. Never attempt to administer glucose orally in unconscious patient. 75. 76. Cardiac emergencies, acute coronary syndrome, cardiac arrest. 76. 77. Acute coronary syndrome. Pediatric dentists will not see many patients with acute coronary syndrome, ACS. However, parents and grandparents who accompany the patient may develop these symptoms. Clinical features: chest pain, tightness, or pressure in the chest. The severity can range from minimal to a severe crushing type of discomfort. Pain may radiate to the neck, back, jaw, and down to one or both arms. Associated symptoms include dyspnea, nausea, vomiting, diaphoresis, profound weakness. 77. 78. Management: place the patient in a position of comfort and perform physical assessment with vital signs. Activate EMS and administer aspirin, 81 mg times 4 chewable, and nitroglycerin 0.4 mg, if the heart rate is between 60 and 100 and BP is greater than 100 systolic. Administer oxygen at 4L/min if the pulse oximeter is less than 90%. Repeat nitroglycerin as needed every 5 minutes, up to 3 times, as long as heart rate and blood pressure remain stable. 78. 79. 2. Cardiac arrest. Cardiac arrest is the cessation of cardiac mechanical activity, determined by the inability to palpate a central pulse, unresponsiveness, and apnea. Uncommon event within the pediatric population. However, when cardiac arrest does occur younger age group, its consequences are devastating. Frequent causes of pediatric cardiac arrest: undetected airway obstruction, prolonged respiratory depression, and apnea. 79. 80. Pediatric cardiac arrest in a dental environment is too often associated with the administration of CNS depressant drugs, for either behavior management, oral, intranasal, or IM sedation, or pain control, local anesthetics. A significant difference from the adult victim is that at the time of cardiac arrest the child's myocardium is already depleted of oxygen. C/F, sinus bradycardia, slowing of the normally rapid pediatric heart rate. Untreated or undetected bradycardia may convert to asystole, silent heart. 80. 81. Management of cardiac arrest: if the pulse rate of an infant or child is 60 per minute and there are signs of poor perfusion despite support of oxygenation and ventilation, chest compressions be started. Defibrillation, less important in pediatric cardiac arrest. Of prime importance is the implementation of basic life support, P rightward arrow, C rightward arrow, A rightward arrow, B rightward arrow, D, as soon as possible. 81. 82. Significant difference in the basic emergency protocol of BLS for adults and children. Adults: when a single rescuer is with the victim with no one within shouting distance, phone first. Activate EMS immediately, before starting BLS, to provide prompt access to defibrillation. Children: since the likely cause of cardiac arrest is anoxia, BLS is initiated immediately. EMS is activated after delivery of BLS for 2 minutes, with one rescuer, phone fast. With 2 rescuers present, one starts BLS while the other activates EMS and obtains the AED. 82. 83. 83. 84. 84. 85. Conclusion: medical emergencies may be rare, but they are challenging occurrences in the dental clinic, tasking the knowledge, skills, and materials available to the practice. Adequate staff training and availability of appropriate drugs and equipment are essential in the management of emergencies that may arise in the dental clinic. 85. 86. Previous questions essay, Emergencies in Pediatric Dental Treatment and its Management. 86.